better
We did it.
Chit chat, Brianna, if you are listening. Can someone just let us know? I'm talking. Can you guys hear me okay? Sounds good. Brianna's saying okay. And then Dr. Tang, do you want to say? Well, let's start off. I'm going to introduce here Dr. Karen Tang. Dr. Tang, can you tell us, first of all, where are you? What do you do? And what your social media handles are?
Oh, perfect. So I am a minimally invasive GYN surgeon. So I specialize in gynecologic surgery for things like fibroids. I'm located outside of Philadelphia. I'm in a practice called Axia Women's Health, and my practice is called the Center for Women's Surgery with Axia Women's Health. So we're just to the west of Philadelphia. And on social media, I am Karen Tang, MD on everything. So Instagram, TikTok recently, a little bit on Twitter, mostly Instagram. Okay, so KARENTANG MD.
So we'll get started. So guys, what we're going to do is I kind of watch as you guys scroll through to see if questions are coming through. I have questions for Dr. Tang, and I'm just going to start asking her, and then we'll take breaks as needed to answer some questions from you guys. So let's get started. So first of all, Dr. Tang, I chose you because of the minimally invasive training. Can you just explain to everyone what minimally invasive means? Well, first of all, you did 4 years of OBGYN, correct? So we did the same thing together. I went on to do maternal fetal medicine. You went on to do?
Yeah, so minimally invasive surgery. So OBGYN as a field has a lot of different subspecialties. So most people who do OBGYN residency will train in doing gynecologic surgeries. They'll, learn how to do surgery for fibroids. But the surgery to do things with minimally invasive access, which is really small incisions, what's called laparoscopic surgery or robotic surgery, is a little bit more difficult. So not every OBGYN will do that type of surgery. So the fellowship training, which is something that is extra training beyond routine, OBGYN residency for minimally invasive surgery is, it used to be 1 to 2 years. Now it's 2 to 3 years on top of regular training.
What does a minimally invasive gynecologic surgeon do? Do you do any more obstetrics? Do you deliver any more babies? Okay. Yeah.
No. So after I finished training, and the acronym is MIGS, just because it's so much to say all of that stuff. So yes, we'll just call it MIGS. No, I haven't done obstetrics since I finished fellowship, or actually even during fellowship, I didn't do it. So I just focus on gynecology. So I do see patients in the office for kind of routine care, but my specialty is doing surgery for things like fibroids and endometriosis.
Exactly what is a fibroid? Because I hear there's a lot of misconception that fibroids automatically mean cancer. Is it cancer first off, and what is a fibroid?
Right. So fibroid is what we call a benign tumor. And I think it's the word tumor that makes people get that sense of. So there are cancerous tumors, and then there are what's called benign tumors, which mean that they're masses, but they are not cancerous. And that's what fibroids are. So they are benign, meaning non-cancerous masses. They grow out of the muscle of the wall of the uterus. So if you picture the uterus sort of like a pear shape, the muscle of the wall of it is where the fibroids grow. And they're actually really interesting. They're basically little cells that kind of just make a whole bunch of clones of themselves and form a little mass. They can be very small, they can be very big, but they're made of muscle and sometimes calcium.
It's interesting.
And that's what fibroids are.
Fibroids are muscle tumors, and the uterus is a muscle. But if you think about it, when a woman gets pregnant and she has contractions to have a baby, it's a muscle causes contractions, and that's what pushes the baby out. So yes, the wall or the body of the uterus is a muscle, and those tumors arise within the wall or the body of the uterus, which is muscle. So, and they're actually, I'm trying to think, those very dense, bouncy balls? That's kind of how I describe it the best. That's what it kind of looks like in some ways and kind of feels like, but it can be pretty discreet within whatever area it is of the uterus, and that's what a fibroid is. And we talk about the different locations of fibroids. Do you have like a diagram you wanted to show, like the different locations of fibroids? If not, I have one pulled up. Yeah. So I'm going to pull it up. And
if you could show yours, just because I don't have to put it on the phone.
What the different kinds are. I'm going to turn you around. Ooh, hold on. Let's see. Yes. Let me make sure.
And I can chat while you're getting it pulled up.
Can you see that? Okay. Wait. There you go.
Oh, that's great.
Wait. Hold on.
That's
Let me
perfect.
get it. Oh, there.
All right. Good.
Really good.
Yeah.
Here we go.
Okay.
Yeah.
In my office, I usually just draw this. So pieces of paper all through my office are just like my hand drawings of fibroids everywhere. So yeah. Perfect. So fibroids, they can grow in different parts of the wall of the uterus. So if you can sort of see, the top fibroid is buried inside the muscle. That's something called an intramural fibroid. Mural means wall. So it's sort of stuck right in the middle of the wall. And then there are fibroids kind of poking out of the outside. So the one on the right is sort of poking out of the surface. That's called a subserosal, which means it's sort of like coming out of the surface. And there's one sort of right in the middle and one right above it, which are kind of in the cavity or just kind of poking into the cavity. So it's important for us to know where they're located because they can cause different types of symptoms depending on where they're located. And also our approach to remove them depends on where they are. So the fibroids, if you want to, go ahead.
And this is underneath the endometrium or underneath the lining of the uterus. And the endometrium is what we shed every month when we have periods. And the submucosal one is probably what people hear about the most, especially if they're going through fertility issues, because it can distort the lining or the cavity of the uterus, which is right here, and prevent implantation of an embryo possibly. And it can also cause abnormal bleeding. And then again, here's a subserosal, which is the serosa is what's kind of the lining of the outside of the uterus. And that fibroid is growing here. Here, that's called a subserosal fibroid. Explain briefly what pedunculated fibroids are. Ooh, where we go, right there. Yeah.
Pedunculated, yes. I saw a question, exactly, a question kind of went by. So pedunculated basically means it's on a stalk. So I'm going to explain it more. It's like a mushroom kind of like coming up off of the uterus with a little stalk attaching it. So you see there's like a little stem. And so pedunculated fibroids on the outside are actually relatively easy to remove because you sort of just kind of like, chop them off, mop it off. So we actually really like seeing pedunculated fibroids because we know it will be pretty easy to remove. Right. And you can actually have pedunculated ones inside the cavity too. There's little mushroom growing.
So they kind of, the pedunculated kind of means
so those
it's
sort of
usually on
the
the
stem
outside,
there too.
The little stalk on the outside of the uterus and then within the lining of the uterus. So sometimes they can be mistaken for polyps, an endometrial polyp. An endometrial polyp it forms from the endometrial or the lining of the uterus. So that's different than having a fibroid. And sometimes if you just do the ultrasound, you can't tell what it is until you actually go in to remove it and send it to pathology. So, and then we'll talk also, here's down here. Can you see that is a cervical fibroid? So fibroids can grow, all of this is a muscle. So the fibroids can grow anywhere where that muscle is, okay? And then also talk a little bit about, I've seen them on the ovaries. Can the fibroids grow in this area as well?
Yeah. Yeah, so fibroids are interesting in that most of the time they're in the uterus, but you can have what's called like parasitic fibroids, or one that's kind of grow in strange locations. So they can grow kind of in the tissue surrounding the uterus. I've even seen them sort of like the detach from the uterus and attach to other parts of the pelvis. So almost all the time they are in the uterus itself, but sometimes they can sort of be nearby. And so, it's kind of interesting how they develop. We're not quite sure sometimes how those came to be. But,
so
the more common ones are obviously in the uterus. And then really quickly, sorry, go ahead.
Yeah.
Oh, yeah. I was just going to point out because Dr. Clark mentioned the ones in the cavity or pushing into the cavity are the ones that can cause lots and lots of bleeding. The tissue in the cavity called endometrial tissue, that's what comes out like period blood every month. So the closer a fibroid is to that tissue, the more it can cause bleeding. So a fibroid doesn't have to be very big. You can have a really tiny fibroid in the cavity and it can cause a ton of bleeding. And so the location actually makes a big difference, sometimes even a little bit more than size. And so, like I said, that's important. And also for fertility, the kind of the topic of the talk, if a fibroid is kind of either in the cavity or sort of compressing it, like pushing against it, that's where it can affect fertility because it can, affect implantation of an embryo.
And we're going to talk about fertility a little bit later, but since we have this diagram of the submucosal fibroids, again, it doesn't, like Dr. Tang said, it doesn't mean they have to be big. The fact it's because of where they're located, they're underneath the endometrium. And if an embryo happens to implant somewhere around there, it may not attach. So that's why you hear of some women having miscarriages that have these submucosal fibroids, or that's how it's diagnosed when they're doing a fertility workup. But if you have a subserosal or an intramural fibroid that is big enough that it's actually growing into the uterine wall, it can also distort the cavity and to not allow and also cervical fibroids, and not allow the sperm to join the egg because the cavity is just not regularly shaped. So those are the two main ways that fibroids can cause infertility, either by not allowing implantation and also causing the abnormal bleeding, or being big enough in any of these locations to cause a distortion of the normal uterine cavity, which is that's how you want it to look, so that the egg and the sperm can't join. So those are the two main ways. Would you agree? Are there any other ways that you could think of that it would cause the infertility issues?
Less
yes,
common,
yes,
but
yes.
if it's like
So yeah,
compressing
sometimes
like
they're
the
big
tube,
enough,
like where the
or they
tube
can be near the
comes in.
ovary
Yeah.
that they distort the tube, and so it can't. The sperm can't get the egg can't travel towards the sperm. The sperm can't travel towards the tube to cause fertilization. So yeah, if it's distorting the uterine anatomy in any way because they're big enough to do that, then yes, the subserosal, the intramural, the pedunculated fibroids can cause infertility as well. But again, the most common time you hear it is when you have the submucosal, which is underneath the lining of the uterus. Okay, so I think that's a really good explanation, and I'm sorry I was a little shaky on that, but I should have just flipped well, whatever. Okay, so how common are fibroids?
No,
so
that was
last
great.
stats that I saw was that about 20% of women of reproductive age have them, but in African American women, they're much more common. 50 to 80% of African American women have them. They not only occur earlier, but in African American women, but they also grow faster in African American women. And it's one of the most common causes of hysterectomy or indications for hysterectomy in that population of women as well. And I had talked to a fertility doctor not too long ago about just issues with fertility in African American women as well. And we discussed the fact that fibroids can go undiagnosed for a long period of time, and then what happens is because women are not not seeking care or don't have access to care for fertility reasons. One of the main reasons is that these fibroids have just gotten so big, and then by the time they're ready to conceive, it's becoming an issue with fibroids. And then also the most common age would be around 30 to 40 years old in any woman to find them, either because they're having abnormal bleeding, or they're growing big, or again, they're trying to get pregnant and they can't. So as far as any other stats that you can think of, I think those are the main ones. I know that they're very common. I will tell you that as someone who does cesarean sections a lot, we pick them up a lot because we do routine ultrasounds, and our patient has a high-risk patient population. We do more than one ultrasound. Right. But there's many women who didn't know, had no idea, had no symptoms, and they might even have a big fibroid and didn't know. So and then the other thing I want to talk about is cervical fibroids. We talked about if it's in the cervix and it's big enough to where it blocks off that cervical canal, then obviously the sperm can't get up into the uterus. So cervical fibroids are not as common, but they do occur. Okay. Do you? Right. Yeah, they do exist.
Yeah,
so
we don't see a whole lot of them, but they do exist. Yeah. Exactly. Yeah. In terms of how common, it's tough because there's different ways to measure like how common something is. So like different ways, the way I kind of explain it is, in Black women, like if you were to do an ultrasound on every Black woman throughout their entire life, you'd pick them up in about something like 80% of women. So it's really, really common. Okay. The interesting thing is a lot of people, sorry, my light's interesting. Sorry about that. It's weird because it looks the same here, but somehow on my phone it looks like it's flashing. So the good thing is that the majority of people who have fibroids will not have symptoms bad enough to require treatment or have any problems with fertility. So it sounds like a really scary number, but it doesn't mean that all of those people will have problems with them. You can have really tiny fibroids that just don't bother anything. You may not have problems with your periods, no problems with fertility. It's definitely a minority of people who have
I think the stat
fibroids which require treatment.
The latest stats in the literature, what they were talking about. 5 to 10% of infertile women, all women, are infertile because of fibroids. So that is, even though we talk about women having them, especially African American women, large portion of them having it, the actual percentage that cause infertility issues is much smaller. So that's another thing we need to make a point of, is that you may be getting a routine ultrasound, or actually having a CT scan because they think you have appendicitis and they pick up fibroids. And I hear a lot of women just they get so scared because they have this small fibroids. But again, most of them do not cause severe symptoms. Luckily for most women. So, right. Yeah.
Exactly. Yes. And so there was a lady in the news recently who didn't want to wear a mask, and this is a little bit off topic, but she said that she couldn't wear a mask because she had fibroids and that affected her breathing. And she had a 2-centimeter fibroid, which every gynecologist who saw that kind of laughed, because we're like, if you do an ultrasound on everyone, you're going to find a tiny fibroid in so many people. That's a pretty normal finding. So we kind of laughed a little bit about that. It's very, very common.
Scans, MRI, CT scans in the ER for something totally unrelated. We always got consulted because they found a fibroid on the scan, and we're like, well, she's not having symptoms.
Exactly.
If it ain't broke, don't fix it. So we
like,
just leave
that's fine.
So, and we're not trying to dismiss anybody that has them, but if you've or told you have
Exactly.
fibroids, I think the key here is to know where they are, how big they are, if they're of any concern, and just make sure that you're aware of it. It does not mean you have to rush into surgery to have them removed. It all depends on what your specific or individual circumstance is.
Yeah.
Right.
Exactly.
Yeah, let's talk about
Yes.
that.
And
Let's talk about
symptoms too. And
symptoms.
I'm sure we're going to talk about that, but
Yeah, so let's talk about
we
symptoms. What are
decide based
some
on
of the most
symptoms. Yes.
common symptoms that women
Yep.
with fibroids might have?
Sure. We kind of divide the symptoms into a couple of different categories. One is bleeding issues. So problems with periods being heavy, long, like lots of clots or bleeding between periods. So in terms of, periods, when we ask patients about, their periods and how much they bleed, the way you're not supposed to ask that question is, do you have normal periods? Because people don't really, have a frame of reference to say what is normal. And I wanted to kind of bring up real quick in terms of, what causes fibroids. Someone asked a question, do we know why it's more common in African American women? We don't actually, but there's probably some genetic component because they do tend to run in families. So people who have a family member with fibroids are more likely to have fibroids. So the interesting thing about that is what I hear a lot from patients is that every person in their family had horrible periods. So they all just kind of thought it was normal. They were just like, oh, you're supposed to go through a whole pack of pads every time you have a period because every woman I know does that amount of bleeding. And so if you go to the gynecologist, somebody who's taking a good menstrual history should be asking exactly how much you're bleeding, how often you change your pad. In general, we say if you're changing or soaking a pad or tampon like every 1 to 2 hours, that's a lot. So, you shouldn't be changing them that frequently. A lot of people will even say like, oh, I have to double up. I have to wear a pad plus a tampon. I'm leaking through my clothes. Like,
Right,
that degree of bleeding is obviously too much.
And I say this, and some people may disagree with me.
Yeah.
I am a huge advocate for period trackers. I think Flow are the two most popular ones. And the reason being is it's really hard to talk to a woman and she's just telling you subjectively what her periods are like. But if she's logging it and the app allows you to tell you to quantify how much you're bleeding, how often you're changing your pads, how long the days last, when they start, when they stop. It's much easier for us to get a gauge of actually what's going on. And plus you don't have to remember, you just log it every day, what's going on with your periods. Whereas if you came in months after months and then you talk to Dr. Tang and you're just like, well, I bleed a lot. Well, it's hard for her to gauge that. But if you have the app and you can show her, do you like having that app information?
I haven't really asked for it, but I do find it helps people to kind of remember what days they bled, like, if they are bleeding between periods or if it seems like they're starting to bleed more and more frequently, that is very helpful. So the people with the apps do seem to have, more kind of like detailed information that helps us to kind of get a sense of how much they're bleeding. It doesn't mean you have to get one if you don't like using them, but it does help to kind of track. And so the things we ask are, like how many days do you bleed? How many pads or tampons do you use on the heaviest day? The flip side of that is how often are you having to change a pad or tampon? And then, how many days between the first day of your period and the first day of the next period. So those are the kind of the stats that we ask for.
Are important to know. Next, obviously pain is going to be major.
Yeah, exactly. Yep. So first category is menstrual bleeding problems or, vaginal bleeding problems. Second category is pain. So they can cause a lot of pain. Classically, they cause really bad pain with your period. So like super bad menstrual cramps. They almost feel like contraction pains. But then people can start to have pain when they're not on their period, like pain when you ovulate or just throughout the month. You can feel it in your back or your sides. It can go down your legs. So those are kind of classic things that people will say, like every time I have a period, I feel like I have shooting pains going down my legs or towards my back. So that's kind of the second category. And then the third category is what we call bulk symptoms, almost as if you were pregnant. Sometimes the fibroids grow so big, they start to push on your other organs like your bladder or your rectum, or just they make you feel really bloated like you're pregnant. So that's, we ask for what's called bulk symptoms. Like, do you feel like you need to urinate a lot? It's almost as if you're pregnant and it's pushing into your bladder. Do you feel like you're having constipation because it's compressing your rectum so you can't quite get a bowel movement out? Or do you feel like just super blooded, like your pants don't fit, or, you feel like you're pregnant because it's just so large. So that's the third category.
Out, so you guys, somebody let me know if the lag is still there. It could be because I had headphones in and Dr. Tang doesn't. So I took them out and somebody just let me know. So, and then obviously the last one would be infertility. You find it because you're not able to get pregnant, ultimately find that possibly a fibroid or fibroids are causing the reason. So So yeah, so when we talk about possible complications, like other than the ones we just talked about, pain, menstrual irregularities, fertility, all that, what are some of the more acute complications of fibroids that might cause a woman to need intervention, surgically or other?
Like urgently. Yeah. So one, you can bleed so much that you literally are hemorrhaging. So patients end up in the emergency room, sometimes needing a blood transfusion or urgent medical treatment to stop them from bleeding so much. It's actually, quite urgent. Sometimes these patients can lose like a liter of blood, like if they're bleeding so much. So that's one. In pregnancy, it tends to happen a little bit more in pregnancy with acuity of pain. Sometimes fibroids do what's called degeneration, which it's a fancy way of saying that they are almost so big they outgrow their blood supply and they start to die inside, and that can be incredibly painful. So sometimes when someone is pregnant and has fibroids, that can happen a little bit more because the uterus is growing so fast. So that can cause people to come in with a really severe pain that needs to be treated. For pregnancy, and Dr. Clark can talk about this more because I don't practice obstetrics, but sometimes that degeneration or inflammation can actually start preterm labor. It actually can cause the uterus to start contracting and lead to labor. So if you want to talk more about that.
Or pregnancy, usually if fibroids are going to get bigger with pregnancy, it happens in the first trimester. Okay, but if a woman already enters the pregnancy with already big fibroids, and typically I think that the cutoff for big is like 6 centimeters, am I right? Where you consider it around 6 centimeters. So 6 centimeters or above, it's a gray area there, but just rule of thumb. But if you already came into pregnancy with big fibroids above that, and I've had women come in with 10, 15, even bigger centimeter fibroids, then what happens is the uterus is growing. So the uterus, the placenta, the baby are going to be getting that blood supply. The fibroid's not anymore. So the center of the fibroid is going to lose its blood supply. And that tissue literally starts to die. That's called degeneration. And when it dies, it releases prostaglandins, it releases all kinds of things that can make you hurt. And those things can cause preterm labor. So yes, I have seen that before. And I have had to deliver women early because they went into preterm labor, because the fibroids got so big that they were causing degeneration and we just couldn't stop the labor. But there's been times where we were able to keep them pregnant as well. So every individual is different. That's just a basic summary of what fibroid degeneration is. Again, it's not for the small ones. A 2 centimeter, 3 centimeter fibroid, it's not going to degenerate, but those bigger ones may. Certain medications, usually what happens in that case, if you have them degenerating, but you're not going into preterm labor, because it doesn't happen with everybody, we treat you symptomatically, because we can't go in and start operating those fibroids when you're pregnant. Unfortunately, it has to occur afterwards, when treatment has to be had. And I also want to add in there as well, when women have big fibroids and they're big enough and they either have to have a C-section because the fibroid is not allowing the woman to deliver vaginally, or she's had a previous C-section for whatever reason and she wants a repeat cesarean section, taking those fibroids out at the time of the C-section is not optimal. And patients just don't, they get kind of frustrated sometimes. Well, you're there operating on my uterus, why can't you take it out? Because one, it's going to bleed a lot. The uterus has a lot of blood supply. And if I start mucking around and digging out fibroids, you're going to lose a lot of blood. The only time we would ever have to take out a fibroid is if it was just there that I couldn't get to the baby without, and that's the
get the baby. Yes.
If we happen to see a fibroid, just whatever reason, that's on a stalk, like Dr. Tang at the very beginning. I was doing a C-section for whatever reason. I happened to see a pedunculated fibroid. Then yes, it's easy because you always do clamp, and cut, and that's it. It's on a little stalk, okay? So that's different than being in the wall of the uterus, being in the endometrium and under the subserosal. You don't want to start taking fibroids out at the time of cesarean section, because that's going to get you into a lot of bleeding and can cause a lot of. So now that we got that out of the way, you know.
Yes, yeah. Like I said, I don't do obstetrics, but
issues for the woman by to have bleeding occur.
Yes.
So where were you going? Yeah, when I entered, where were you going?
Oh, no, I was just agreeing with you. I don't do obstetrics anymore, but I remember in residency, people would ask that all the time. They're like, oh, if you're in the C-section, just take the fibroids out. The surgery to take fibroids out of the uterus called a myomectomy, under the best of circumstances can lose a lot of blood because, like Dr. Clark was saying, the fibroids grow so large because they recruit a lot of blood vessels to feed them. And so even under non-pregnant circumstances, you can lose a good amount of blood just cutting the uterus and taking the fibroids out of the muscle. During pregnancy, the blood volume, it grows enormously, and then you get very big blood vessels feeding, almost like little garden hoses. And you would get into a lot of trouble if you started cutting into a pregnant uterus, not just for a C-section, which is in a different area, but, like I said, I don't think anybody would be brave enough to cut fibroids out of the muscle of a uterus of a, full-term pregnant uterus. So that would be a lot of bleeding.
Done a handful of times. Usually we could find an area on the uterus that we can avoid it. We try to do that at all possible. There's been a handful of times where you just couldn't, and you have to, but we let anesthesia know. We, make sure we have blood available just in case there's extra bleeding. And most of the times there is, and we have to address it then. I'll give you a little visual help, sir. So just say like this might be the size of a blood vessel in a non-pregnant uterus. By the time she's full term, it might be this big. Vessels engorge because all that blood flow, you're getting 500 cc's to a blood, I think it's a second, to 5 mLs. And you can lose a lot of blood very quickly. So, you want to do the most that you can to avoid getting into extra bleeding. Okay. The main ways that fibroids are diagnosed.
So we can diagnose them on exam. Sometimes if we're doing just like a routine pelvic exam and we're checking the size and the shape of the uterus with, kind of a manual exam, you can sometimes feel them. You can feel like the uterus is large. You can feel the kind of masses, but a lot of times they also, we'll get an ultrasound based on someone's symptoms. So someone will come to us and say, I'm having really heavy periods, having lots of pain. The first imaging study we order is something called a pelvic ultrasound, which is, what is used in pregnancy. Is basically using sound waves to look at the uterus. So that is sort of our routine imaging study. Sometimes we'll ask for an MRI as well. Like if we're doing something like a myomectomy surgery, we'll have an MRI to better kind of map the fibroids. You don't have to have an MRI. We only use it sometimes, depending kind of on the removal or, procedure we're planning to do. But ultrasound is sort of the most common way. So either if someone has fibroids diagnosed based on an exam in the office and or as part of the workup for their symptoms.
I keep getting a lot of questions, so I want to stop and answer it. Mm-hmm. Removal of fibroids before pregnancy. I'm going to talk about from an obstetric point. If I had a myomectomy prior to pregnancy, it's very important that I have access to that operative report, because I need to know, first of all, where that fibroid was, how deep they had to go into the uterus to take it out, and whether or not taking that out meant that they had to enter the uterine cavity. If that's the case, then you don't want to labor, because you could rupture that old scar where they took that fibroid out. So that's why you hear a lot of women who have had fibroids taken out prior to pregnancy, why we recommend a C-section. And it is a legitimate concern. You don't want to rupture that uterus typically, and it depends on the doc or how severe the surgery was. Typically we let you go to about 37 weeks. That's what I do, unless there's some other extenuating circumstances that makes you requires that you be delivered earlier. But based on just a myomectomy prior to pregnancy, if it entered the uterine cavity and there's high suspicion, then yes, we would recommend a C-section to avoid that area from rupturing, because that is a real obstetrical emergency for both baby and mom. Now, regarding just removing them, you're told you have a fibroid. And I want to get pregnant, should I have the fibroids out? What would you say?
Yeah. So that was a good question. I saw a couple of questions go by of like, I have this type of fibroid. Should I get it removed? So we go based on a couple of things. We sort of kind of touched on a few of them. Number one is based on symptoms. So again, if you have small fibroids and you're not having any symptoms, it sort of came up on imaging for something else, like they were looking for appendicitis and saw some fibroids. If you're not having any symptoms, I always tell people it's really hard to take someone who's feeling great and make them feel better by doing a procedure or surgery on them. So in general, if you're not having symptoms, sort of our default is to not touch them because, again, they are, sometimes we're cutting into the uterus to remove them. There are risks with any procedure. If you take someone who's feeling great, like I said, and you're trying to make them feel better by doing a surgery on them, it sometimes doesn't make sense. But the exception is when we talk about fertility. So if there's a fibroid that looks like it's compressing the cavity, we'll at least discuss the potential that it may have some influence on fertility in the future. There's unfortunately no way to know. And so, when we say that it's possible, it doesn't mean that it necessarily will cause a problem. I say we don't have a crystal ball, so we don't know if you were to leave it alone, would it cause a problem? Would it not? We unfortunately don't know. So when we counsel people, we actually just have to kind of lay everything out there that it's possible this fibroid that's kind of compressing your cavity, it might make it a little bit more difficult to get pregnant. There could be a risk of miscarriage. But then there's also risks of the procedures. So in general, we kind of have to have that whole discussion with the patient, and then I let them decide, what their preference is. And again, if they're having symptoms, it's pretty clear that we're going to go down the path of treating it. If they're not having symptoms, that's where it's a little bit more kind of, up to the individual patient about, what their preferences are about, how important is fertility to them. Not everybody actually, it wants to get pregnant.
Yes,
so if they don't want to get pregnant, then we just say, let's keep watching it.
What your symptoms are. If you're having symptoms and you are already having symptoms and you're considering having a baby, then you might want to get that addressed. Or if you may not be having symptoms, but you're not getting pregnant and there's a submucosal fibroid or a larger intramural that's distorting the cavity or anywhere else, then you might want to get it taken out.
Exactly. Yeah, I forgot to mention if someone is actually having problems getting pregnant or having miscarriages and they find a fibroid, then yes, that is definitely an indication to remove
here
them.
For always getting a second opinion. Okay. I do think that if you have someone like Dr. Karen Tang who does minimally invasive surgery for things like fibroids in your area, to speak to someone like her, because this is what she does. This is day to day, and all of us when we specialize, that we have certain things that we do day to day, and this is what she does. So she has a lot of experience, and there's a lot of more and more of they're called MIGS surgeons or minimally invasive gynecologists around. So there are available to, if you have access, get a second opinion from someone like her, or in conjunction with someone like Dr. Tang and your fertility doc if you're going through infertility issues. Discussing whether or not that is necessary to do before you get pregnant. There are some things that the reproductive endocrinology and infertility specialists can do regarding removal of fibroids, and they will let you know if that's something they can handle. But if not, then you may need referral to someone like Dr. Tang, who does the minimally invasive. Is that kind of what you?
Yes. That's perfect. Yeah. And actually, that's a great kind of bigger point about who do you go to see about your fibroids. So I think most people will go to start with their general OBGYN. And like we sort of said in the very beginning, a lot of OBGYNs will do, the whole range of treatment for fibroids. We haven't kind of touched on this, but the fibroids that are removed in the cavity, something called a hysteroscopy. We would go through the vagina to remove fibroids, the cavity, myomectomies from above. So a lot of general OBGYNs will do all that. The tricky thing is, and what I hear from a lot of patients is sometimes the general OBGYNs don't feel comfortable with some of the in-between stuff like myomectomies, especially from like a minimally invasive perspective. So you get a lot of people who kind of pretty quickly jump right to, you're going to get a hysterectomy. So that has been kind of problematic. And I hear this a lot from patients who they go to see their general OBGYN. They're like, oh, you're just going to get a hysterectomy. You're not going to be able to get pregnant. Like, we just have to take the uterus out. So if you ever feel uncomfortable with what your doctor is offering you, if you care about fertility and they're saying you got to get your uterus out, that would obviously keep you from getting pregnant. Definitely go see someone for a second opinion. The fertility doctors was called reproductive endocrine and fertility doctors, or REI doctors. A lot of them do also do these fibroid removal surgeries. Some of them don't. Some of them just do kind of like, like IVF type treatments. But a lot of them do surgery as well. And they also specialize in this. So minimally invasive GYN surgeons or fertility surgeons tend to be the more specialized doctors who treat fibroids. So that's an excellent point, because I think a lot of people get sort of stuck because, they see their OB and they tell them something that just is a little bit, not in line with what their desires are. And then they're not quite sure where to go next. And so that's a big problem, actually.
When trying to get pregnant or you're done having pregnancy, having children, if the hysterectomy is being recommended, and it's always okay to get a second opinion. And it's okay to get a second opinion for anything, ever. So, if you're just not there yet, or you want to see what someone else has to say, that's perfectly, okay to do that, especially before you have a major surgery like a hysterectomy for any reason. So, unless of course it's an urgent situation and it can't be avoided, but, if there's time and you can get a second opinion, that's always been your right. I just wanted to, some people are asking about the effect of fibroids on pregnancy. So the main thing you hear about, and it's usually going to be the bigger fibroids, okay? Not the little 2 to 3, 4 centimeter fibroids. It's usually a woman that's got large fibroids, either multiple or even one big one. If it's distorting the endometrial cavity and doesn't allow the uterus to grow and accommodate that baby, and have the space that it needs to grow, that can be an issue. It could cause the placenta to have issues. It could cause growth restriction because, again, that fibroid's taking blood that should be going to the placenta. So, it could cause growth abnormalities in the baby. We talked about it earlier, preterm delivery, because either the fibroid is degenerating and releasing those prostaglandins that cause your uterus to contract and put you into preterm labor, or preterm labor because there's just not enough room. The baby can't grow any bigger because the fibroids are in the way. As a result, the uterus is like, well, I got to get rid of this baby. So that's kind of nature's way. And there's not enough room anymore. The baby has to go. So that can cause preterm delivery as well. Fetal malpresentation. The baby gets in there a different upside down, like breech or transverse or side to side instead of head first. Not allowing the baby to come down into the birth canal like it should because the fibroids are in the way. And then obviously we talked about this infertility or miscarriage, because the embryo is not allowed to implant because of either the distortion of the endometrial cavity or the fact there's a submucosal fibroid there that's not, or more than one, that's not allowing the embryo to implant. So those are the main reasons or main complications you can have in pregnancy. If we do see fibroids as someone like myself, a maternal fetal medicine specialist, depending on where they're at, we can tell pretty early on, especially by 20 weeks, because usually by 20 weeks, they're not going to get bigger. That's kind of where they're at. And the 18 to 20 week mark is when you get an anatomy scan. So by then they're probably done growing, and we know where they're at. We know how big they are, and we can kind of tell you, I think the baby's going to be fine. You're going to go, head first, and you could deliver vaginally, or no, there's a big cervical fibroid there. The baby's not going to come out that way. We need to start talking about where this possibly cesarean section. So those are the main things, and it's always good to talk to your doctor about what to expect. I saw a cat tail there.
I know, my cat just like waved its tail from the camera.
Can cause issues in pregnancy. They can. But we do the best that we can to get you as far along in the pregnancy as possible, especially women that have those very big fibroids, and also to control the pain should they start degenerating. So I think we talked about all the pregnancy stuff, and I wanted to just mention real before we start answering questions, so we have a little bit of time here. As far as minimally invasive surgery, what are some of the techniques that you use as a minimally invasive gynecologic surgeon to handle fibroids? Like, what are some of the things in your wheelhouse, or
what can we do? Yeah, so the main thing that is different from what a general OBGYN usually is able to do is either, laparoscopic myomectomy or laparoscopic hysterectomy, meaning that we do the surgery instead of with a traditional incision that's like a, what we call like bikini cut, or like what is used for a C-section incision, sometimes even a really big up and down incision, is we do the surgery with really tiny incisions, and we put instruments in with a camera, and we remove everything that way. So that's always preferable if someone can do a surgery that way, because there's less pain, there's, a shorter recovery time, less risk of things like hernias, so like less time that you have to kind of restrict your activities afterwards. So in general, if someone can do a surgery, minimally invasively, we always prefer it, or it's always better for someone. The trade-off is that, one, it's more technically difficult, and number two is that the surgeries tend to be a little bit longer. The other kind of limiting factor with fibroids is you have to get them out of the body. So, if you have incisions this big and your fibroids are this big, we have to remove them from the body somehow. So that always adds a little, a lot of time to the surgery, because through the small incisions, we have to kind of, use a scalpel to kind of remove the fibroids. We used to have a device that did that, something called the morcellator, and this is something that people may have heard of in, in the news or in like looking up fibroid surgeries. There's something called the power morcellator, which was basically a spinning blade with an instrument that we would kind of pull the fibroids out in strips, or the uterus out in strips. Most places are not allowed to use that anymore. We haven't touched on something called sarcoma, which is, when we started all this, we said that fibroids are benign, they're non-cancerous. There is something that is a cancerous tumor that looks exactly like fibroids. Fortunately, it's extremely, extremely rare. But there was a case, maybe like 10 years ago now, something like that, where the patient had what looked like big fibroids, ended up being that super rare type of cancer. They had used that device, and, there's a question of whether, breaking it into pieces spreads cancer. This is not to scare everyone. I always have to kind of give the caveat that that type of cancer is extraordinarily rare. Like in my 10 years of doing surgeries on fibroids, I've had one patient with that type of cancer. And especially if you're, younger than age 50, it's almost like a 0% risk of that. The trouble is that because of that one case, now we're not allowed to use that device for benign fibroids either, just because there's no way to kind of, tell. So that has sort of limited some of the surgeries and our ability to do, like really large fibroids, is just because you would, not have enough time to be able to remove like these enormous fibroids through teeny incisions. So like I said, in general, I like to try and do as much as I possibly can through laparoscopic surgery. Some people may have heard of robotic surgery. The robot is just sort of a tool. It's not a different type of surgery. It's just an instrument or, a platform that we use to help us do the surgery. It just helps us to suture. So I use that sometimes for myomectomies because we do a lot of stitching with those surgeries to kind of repair the walls of the uterus when we've cut the fibroids out. So that's the only surgery I do with a robot, just because there's a lot of stitching, sometimes at really hard angles. Robot wise, I just use that. But that's not something that, you shouldn't need to look for a robotic surgeon, or, that's just a tool. So sometimes people get a little confused about, what's a robotic surgeon, what's a robot. It's just an instrument we use. But those are the techniques that we offer. There's another category of treatments which is very new. It's not offered everywhere. Things where we're actually ablating the fibroids, something called Acessa, which some of you may have heard of. It's basically using the laparoscopy, using a camera, and kind of guiding insertion of probes into the fibroids and using energy to destroy them. So that's something else that's kind of coming down the pipeline. I'll hopefully be offering that sometime in the next year. There's a couple of surgeons throughout the country. It's not very widely available, but hopefully as, we will start to offer that more and more. So it's another option as an alternative to the myomectomy, with just less blood loss involved, because you're not cutting the fibroids out, you're just sort of destroying them. There's another category which we don't perform as surgeons. It's something that radiologists perform. It's called uterine artery embolization, or uterine fibroid embolization, UAE, UFE. They feed catheters through your wrist or your groin and basically block the blood flow to the uterus and the fibroids and shrink them. It helps with bleeding, makes them smaller. It's not recommended for people who want to get pregnant because, like Dr. Clark says, the uterus depends on blood flow to feed the placenta and feed a pregnancy as it grows. So blocking the blood flow of the uterus is not ideal. There's kind of nuances to that, but in general, if someone wants to get pregnant or is planning to get pregnant, that's not something that they recommend pursuing. But that's kind of the kind of scope of what we would do. And then the final thing, which we touched on, is hysteroscopic myomectomy, which is if you have a fibroid that is in the cavity of the uterus, like we saw in that picture, we can actually reach it with a camera through the vagina into the cavity, and we can kind of shave it down from the inside. We can't do it if it's an enormous fibroid. So the instrument's only about that big, but small to medium-sized fibroids in the cavity, we can remove that way. So, in general, make sure you see your doctor because all of this is very individualized. So it depends on, someone mentioned how big they are, where they're located, things like that. And so we'd have to individualize the decision for each patient.
Let's talk about the blood flow to the uterus. It's actually 500 to 600 cc's or milliliters per minute. It's why, I said second, but it's minute. Mm-hmm. It's
still a lot. It's still a ton. Yeah.
Again, that's another reason why you don't want to remove C-sections, fibroids at the time of C-section. B, the uterine artery embolization, or UFE, the uterine fibroid embolization that Dr. Tang was just mentioning. If a woman has plans for having children in the future, that is not an ideal thing to do. So because we don't want to decrease any potential other blood supply. And just so you know, when they do that, it's not that they decrease all the blood supply to the uterus. They can figure out kind of where the blood supply is going to that specific fibroid to that. But you know, the vessels are vessels, and you could potentially decrease blood supply to the uterus that you might need for a pregnancy in the future. I will say that also, and I haven't done this in a long time, and I try to avoid it as much as possible. When I first started residency in 2000 is when laparoscopic got really big. And after my first handful of cases, like I'm never doing it again. I'm done. I had the patience, so I am so impressed by you guys to do it, because I can't do it.
It's hard. Yeah, they're hard surgeries. That's what I was saying. Not a lot of people do them. So you're trying to suture with like these sticks and like hard angles. It's difficult. It takes a lot of practice, a lot of training. Yeah.
And also one reason why people might recommend the UAE or the UFE is if you're not a good candidate for a major surgery. You have lung issues. You might be obese beyond a certain point that putting you to sleep would not be safe. Or other kinds of medical conditions that general anesthesia or putting you to sleep might not be ideal. Or if you have severe bleeding that needs to be treated acutely and you can't go to the OR operating room for whatever reason to have your uterus removed. Those are some of the other indications to have. Does that still hold true?
Yeah. So where we saw this a lot, like where patients would get admitted through the emergency room, people who had blood clots and were on blood thinners. So they were being treated for a blood clot with a blood thinner that obviously causes bleeding. They bled so much that they were very anemic. Patients with blood clot are at a higher risk of surgery. You could have a blood clot that could kill you. And then you're already so anemic that there's a risk of surgery that your body would be too weak to handle the surgery. So those patients we really don't want to take to the OR to operate on them. So, very often we would actually have the radiologist do an embolization to stop the bleeding. The other issue with those patients is that we can't give the medications we usually give to stop bleeding because all of them can cause blood clots. And so those patients don't have a lot of options left. So we end up doing embolizations emergently to save their life, basically, because, you sort of run out of other options. And so, like Dr. Clark said, there are some times for medical reasons that we recommend that over other options.
And we're going to answer some questions. We have about 12 minutes left. So can we detect it on a routine ultrasound? If they're big enough to be detected, yes. When you're doing a routine ultrasound, either in pregnancy or not, you could see fibroids, especially on a transvaginal ultrasound. So the answer to that question is yes, most of the time. Now there might be a little 1 centimeter or 2 centimeter that is just not big enough for us to pick up. But usually I would say around, 3 or more, you're usually going to pick them up, 3 centimeters or more. And you can, will know that if you're getting an ultrasound of your pelvic anatomy for whatever reason. Okay, let's see. What? Oh, so we were talking about where would a fundal pedunculated fibroid be? Okay, so if you think of the uterus like a balloon, the top of the balloon or the top of the uterus is the fundus, okay? And a pedunculated fibroid would come off any part of that top part of the balloon. And it's on a little stalk like this, maybe like this. And then the fibroid can be on a stalk, it'd be little, or it could be on a stalk, it'd be very big. So I've seen them actually pretty big off the uterus, right?
Yeah, you look like a little pumpkin, like on a tiny stalk. It's actually pretty interesting how they grow that way. Yeah.
Someone's telling me they have a 2 centimeter fibroid. Should I have operation? I mean, it depends on where it is. A 2 centimeter fibroid that's not distorting your uterine cavity. I don't know that I would do anything about that, but I don't know what your situation is. Agreed. If there's symptoms, it all depends on the symptoms and if it's distorting the uterine cavity and you're trying to get pregnant. Agreed.
Yeah, and then I tell people actually really small fibroids we oftentimes can't even find. So they are buried inside the wall, and the wall is bigger than 2 centimeters and stuff. So if you picture it's like a little pebble kind of like lost in the muscle, we can't actually even find them to remove them. So I tell people the really teeny ones, unless they're reachable from inside the cavity, we actually can't even find them a lot of times to remove them. It's in a weird way, it's a lot easier to remove if they're big so that we can locate them. So yeah, if you have a smattering of 1 centimeter fibroids that aren't in the cavity, we actually can't really remove those unless you've already got a big cut to take a big one out, and then you can find the little ones. But that's okay. Oh, that's great. Somebody's going to come see me soon. I look forward to meeting you.
This is so weird. How this? Okay, I'm trying to find the other one. We already talked about fibroids in pregnancy. And, you know, I wouldn't say they're dangerous. I mean, I've never, you know, other than miscarriage and early pregnancy loss, you know, I've never, you know, it's usually been a preterm labor situation. And sometimes we get stopped at preterm labor or not. And they're dangerous in the respect that, you know, I see either preterm labor or pretty painful for the mom. And it's hard to regulate that pain because our options are kind of limited as to what we can give you. So that, and again, that's very rare. I've seen it a handful of times in my career where, you know, it was a significant issue as far as the pain and the degenerating fibroids. Thankfully, it's not something that's that common. Let's see. We talked about removing fibroids for pregnancy. And the second question is, okay, please advise. Wait.
I can kind of jump on. There's that question, also the question about like how long should you wait to get pregnant, and you know, like should you get surgery before you try and get pregnant? In general, like ideally, and there's not like a lot of data behind this, but sort of our gestalt is we tell people to wait something like 4 to 6 months after fibroid surgeries where we're cutting into the muscle of the uterus before you try and get pregnant, just to give you plenty of time for your uterus to heal. Just because when you're pregnant, it is a big stress. The uterus is growing and things like that. So you know, for the most part, we say wait a couple of months, like on the order of 4 to 6 months. There's some nuances again to that, depends on how old the patient is and other circumstances, but we do ask people to wait a couple of months after. So that might factor into when people decide to have their procedure.
And I think I know what the answer is, but I see a lot, and social media is a wonderful thing, and we're both on it, so we clearly think it's wonderful. Say now why I'm on it is to give accurate information. That started for the very beginning because there's a lot of inaccurate information out there. So, a lot about I took this supplement, my fibroids went away, they shrunk.
Oh no. Yes.
Is there anything I can take orally? Anything I can drink, eat, supplements, go to GNC and buy, anything I can go to Peru and find that will shrink my fibroids?
Yeah. I know. So yeah, unfortunately, there is a lot of this on social media and, you know, like emails and things like that will say that you have like this herbal supplement that will shrink your fibroids. Unfortunately, there's nothing that we know of. You know, there's some association with like vitamin D deficiency and fibroid growth. Again, nothing we have like a ton of data on, but there's no supplement that you can buy that we have like research that proves that it decreases. In general, with things like pain or bleeding, I have had a lot of people say that they had improvement in some of those symptoms depending on like, you know, changes they made in their diet, you know, so-called like inflammatory foods like, you know, gluten and dairy and sugar and things like that. If you get rid of them in your diet, it's actually, you know, it's good for your health. It's not a bad idea, you know, and it might help with some of your symptoms, but, you know, it's not going to shrink your fibroids. So, you know, I just tell people there's no harm in trying things like that. But again, if someone's saying, I'm going to sell you a supplement that has herbs and it's going to make your fibroids go away, just run away, because there's nothing that we know of that is proven to be true about that. So like I said, the things are just, you know, good for your health in general. It can't hurt to give it a try, and then it might improve. I have had people who weirdly the bleeding actually just completely improves just with some of those changes, but the fibroid is still there. The one thing that does tend to kind of make them smaller is menopause. So they are fed by the hormones of the ovaries, and so when people go into menopause and those hormones go down, the fibroids do tend to shrink. And if they're small, they can't even disappear. But if they're large, they may go from like this to like, you know, like this. You know, so menopause is the only thing that kind of naturally makes them
most
shrink.
Patients that have a myomectomy return for additional surgeries in later years for other fibroids, or do most of your patients not need surgery again?
Yeah. And this is where I tell people it's hard to quote like statistics because every person is different. So in general, like in studies, like up to 40% of people who have a myomectomy may need another procedure in the future. It's just because, again, they're fed by the hormones of the ovaries. If your ovaries are still working, you know, whatever causes fibroids to grow, they can grow more. So the fibroids that you've removed obviously are gone, but your uterus can still make more fibroids that could come back. So, you know, one of the limitations of all of the options short of a hysterectomy where the whole uterus comes out is that the fibroids could always grow again. So that's part of our counseling when we tell people about the risks and benefits of different options is that anything where we leave your uterus behind, they can grow again. So I always say that there is always a possibility, you know, that you could have a myomectomy. You know, sometimes they never grow again. So if somebody has one fibroid and they're like 35 and then you take it out, then, you know, the chances are it probably won't come back. But if someone has a lot of little fibroids, they're, you know, 25, they're young, there's a lot of years before they're going to go into menopause. And we say there's actually, you know, like a higher chance that they could come back in the future. So again, it's also personalized. You know, I don't tell everybody that your individual risk is 40%. I say of all the women who have had myomectomies, you know, somewhere in the range of a little bit less than half of them might need something in the future. You know, but it's just something that, you know, so you're aware that if your symptoms come back, if you feel like your uterus is getting bigger again, you know, come back soon so that we can do an ultrasound.
And then we'll wrap up. How long after fibroid removal is it safe to get pregnant? So I think it would depend on A, where the fibroid was, and B, did they have to enter the uterine cavity? So let's talk about submucosal fibroids. Submucosal, again, are the ones under the lining of the uterus. Most of them are on the smaller side and they can be taken out. So if you have a patient that you're taking out a submucosal fibroid, how long would you tell them to wait to get pregnant?
Yeah, that one can be a little bit sooner because the lining, the endometrium that kind of coats the cavity, like tends to grow pretty quickly. So within like one cycle, usually it's kind of come back and healed over. So I tell people something like 1 to 2 cycles, they can get pregnant. If we're cutting the muscle, so if we're doing a myomectomy and actually cutting the muscle and taking them out, that's a weaker spot that takes a lot longer to heal. So that's where we say like something like, you know, like minimum 4 months, probably, you know, 4 to 6 months if you can wait to make sure that it heals well. And so I leave this up to kind of some, you know, different surgeons have different preferences. So sometimes if patients are fertility patients and they're under the care of a fertility doctor, you know, they may know different circumstances about, you know, if they're worried about like the cavity and things like that, they may even wait longer, you know, so I'll usually leave that up to the fertility doctor. But in general, after hysteroscopic, if it's in the cavity, we're removing it like 1 to 2 months.
And then
if it's
you're
cutting
having
the muscle longer to let the
fibroids,
uterus.
or you're having a big one removed and they had to enter the uterine cavity, it's going to take longer because you kind of consider that as actually, in a way, you're doing enough of the incision. It's kind of like having a C-section in a way. So you might want to wait a year to 18 months to get pregnant.
Yeah,
but
exactly.
You have to ask questions. You have to ask your doctor, hey, that were in your uterus, right? They're the ones that saw what was going on, and you got to have that question answered. How long should I wait? And you're going to have to ask the question. You need to trust your doctor's response. If they tell you, I recommend waiting a year, there's why they told you that. They're not trying to be, then you should listen, because you don't want to increase, especially for these big myomectomies that women have that are intramural, that go into the uterine cavity. There's a reason why, because we don't want you to get pregnant and increase your risk of rupturing that uterus, because we want that uterus. So always ask, no matter how small the uterus, ask, how long should I wait? That's a perfectly good question. And most of all, but trust.
Yes. They should be answering. Yeah. As I say, your surgeon should be giving you that answer regardless. If they don't, make sure you ask them, because it's so individualized. Like, you know, Dr. Clark said, depends on how many cuts we made, how deep the cut was, you know, like where they're located. So, you know, the surgeon should give you a recommendation based on what they did.
Either on the inside uterus or about, so what we're talking about, uterus in the wall, the uterus is a balloon. It's in your body, and it can be anywhere on that balloon. The front side of the balloon, uterus, the back side of the balloon, the top side, the fundus, down on the cervix. So it doesn't matter where it's at on the back side. It just means it's on the back side towards your rectum or your spine, versus the front side, it's towards your abdomen or your bladder. It's just within the wall. So it doesn't, they're all treated the same way depending on where they're located. Okay.
Right, exactly. It's more like how deep inside versus like the surface versus like inside of the cavity. So
Okay,
yeah, it doesn't exactly matter like if it's front or back.
I'll have it's going to cut me off in 5 seconds. So thank you so much.
We
I
did
appreciate
it.
it. You were awesome. Thank you. Bye.